Hello, good afternoon, everyone. We are Sucheta and Ayan from Florence, Alabama, and we are going to present a case which shows us a rare fatal post-COVID complication. We know that COVID-19 can lead to various pulmonary and extrapulmonary complications. Some of them are common and some of them are rare. The rare complications can be fatal, like tension pneumothorax, hydropneumothorax, or even loculated pneumothorax. So herein we present a similar rare case wherein a patient of the age of 59 years old gentleman, he came in with complaint of increasing cough and shortness of breath for about 4 days prior to presentation. Of note, he had a history of COVID around 6 weeks, 2 to 6 weeks prior to presentation. He required some oxygenation during that time, but he did not require any positive pressure ventilation. He was treated conservatively and discharged home. But this time when he came in during presentation, he was saturating around 74% on room air and required up to 15 liters of oxygen via non-rebreather mask. His air entry was reduced on the right side, and a chest X-ray done during that time showed a pneumothorax for which a 24 gauge chest tube was connected to water seal, following which his saturation improved. However, by next day, the patient's respiratory status worsened and he again developed tachypnea, hypotension, and the chest X-ray done during that time showed evidences of loculated hydropneumothorax and evidences of tension pneumothorax, because of which an emergent second chest tube had to be put in. A repeat CT of the chest was also done, which corroborated with the findings of the chest X-ray. We started the patient on pressors, and patient had to be intubated as well, and started on broad spectrum antibiotics. CTVS was consulted in because of the latest findings. And they suggested that because of the developments, the patient won't improve with chest tube and would probably require VATS. However, the patient was too sick by that time to undergo any surgical intervention, and he unfortunately passed away despite best of our efforts. Why we decided to present this case was this patient did not have any pulmonary comorbidities, and even during COVID, he did not require any positive pressure ventilation, but still went on to develop pretty serious sequelae. In literature review, we saw that in COVID patients who require positive pressure ventilation, up to 15% of them can develop pneumothorax. And even in patients who don't require mechanical ventilation, up to 1 to 2% of patients can develop these kind of complications. However, patients developing serious complications like tension pneumothorax or hydropneumothorax are only handful. The hypothesis behind this is that probably there is direct alveolar damage in COVID because of microthrombi formation or the cytokine storm. And there are also theories regarding chronic cystic changes in lung parenchyma caused by the direct COVID infection. And the risk factors include patients who have had prior lung pathologies or history of smoking, history of COPD, emphysema, or even male gender has been found to be a risk factor. So because of this, we would like to conclude that even in COVID patients who have not been serious during the infection per se, it's safe to repeat an imaging study maybe 4 to 6 weeks after the infection resolves, and keep a low threshold to suspect these kind of serious sequelae developing in these kind of patients. That's all from us. Thank you so much, and we would be happy to answer any questions.
All right, thank you very much. Are there any questions? All righty, thank you. We can go ahead and move on to the next presentation.